I thank the AIOS for this opportunity and the UKSOS for this opportunity to speak on macular hole surgery. And so I'll be showing you a few cases. This is my first case with a 59-year-old female with diminution of vision in the right eye, 660 vision. And this is what the macular hole looks like. And these are the dimensions of the macular hole. And I'll just quickly show you the video. So as we know that nowadays we do the inverted ILM flap for bigger macular holes especially. On intraop OCT we find however that the flaps are not within the hole or they are not opposing onto the hole. So I just put a PFCL bubble and I use this finesse loop which is quite atraumatic and is able to just gently nudge the flaps into place, which is again confirmed on the intraop OCT. And then of course going ahead with air fluid exchange and C3F8 gas tamponade. So this is what the patient looked like, and BCVA improved to 624. The second case, a 50-year-old male presented with DV 3/60 vision, a large macular hole, and following first surgery the hole closed, but when the gas, it appeared closed, but when the gas volume decreased, we see that there is a recurrence of the macular hole with a kind of a type 2 closure which we are seeing. So again, this is re-surgery for this patient. I'm not sure because of the bright light if you can see the contrast, but the flaps are not inside the hole, and on staining we see that the flaps are kind of reflected and they've fallen out of the hole. So again, in this case, using the finesse, these flaps are kind of stuck to the surface of the retina, but they are not very densely adherent. And with the finesse loop, I find that very atraumatically I could, dislodge the weakly adherent flaps. And again, intraop OCT shows that the flaps are back in place, and I go ahead with the air fluid exchange. And following the second surgery, so basically PFCL in both these cases acted as a very nice third hand to push the flaps within the required space. This is a case of a high myope with macular hole RD, a 76-year-old with 636 vision. Post macular hole surgery, macular hole closed. But again, he had a recurrent macular hole with retinal detachment and vision going down to finger counting close to face. So this is a re-surgery for this patient, and I just removed the residual gas. This is, I'm taking out the trocar because I use 25 gauge, but these instruments don't reach the posterior pole in very high myopic eyes. Without PFCL, you were seeing that I was struggling to peel the ILM, but with PFCL in place, it provides counter traction, and now I can peel the ILM. These steps are little difficult to do, but somehow I was able to manage, and also I had to use a spring kind of forceps from a special forceps for these highly myopic eyes. And post silicon oil injection, this the macular hole closed and the RD settled down, and this is the post-op picture that you can see. This is a case of giant macular hole, and this had undergone macular hole surgery elsewhere. This is almost 2400 microns. So I'm doing, as I did the vitrectomy, I saw there was an RD in the periphery and inferiorly, which this patient was previously operated, and this is a giant crater. So I'm looking for any residual ILM. I could not find any residual ILM. I'm putting a chandelier here, and after putting this PFCL bubble, I try to find nasally if there was some ILM, but again, I'm unable to do it. So this inferior RD, I just mark an area and take an autograft, a retinal transplant, and with two forceps under PFCL, I'm able to place it over the giant macular hole, and then doing the air fluid exchange, and of course doing laser around the area of retinotomy. This was my first case, so I took a smaller graft than I should have. So you will see that there was a mild retraction of the graft, and so I couldn't really achieve, the edges were not flush with the macular hole edge. This is my last case of a myopic macular hole post VR surgery with oil. So again, there was a macular hole post silicon oil injection, and took this case up for re-surgery. So sometimes macular hole can develop even if it was primarily not there because of myopic traction maculopathy. So intraop OCT helps us to, especially when there is lack of contrast in some of these highly myopic eyes with posterior staphyloma, the intraop OCT is a useful tool. Here I'm just trimming the flaps because if you have very large flaps, and again I'm confirming on intraop OCT that the flaps are snug onto the hole. This is more a problem in highly myopic eyes with posterior staphyloma and lack of contrast, where this really comes in handy. I won't go into some of the theoretical concepts because we are running late. But just to conclude, PFCL assisted inverted ILM flap technique can be used as a primary approach for large, chronic, and recurrent macular holes. The nitinol loop can be used very efficiently and safely to manipulate the ILM flaps under PFCL. Autologous retinal transplantation can be the last resort when conventional surgery fails and ILM has been exhausted. And PFCL acts as an efficient third hand, and intraop OCT is a useful third eye adjunct in achieving successful outcome. Thank you.
Thank you, Saurabh. Since Dr. Cyrus is present here, I'd like to have his comments instead of question answer. And next speaker is Dr. Satanshu Mathur.
Mike.
Yeah, thanks, Dr. Lee, and a wonderful presentation, Saurabh. Just a few things. I think you mentioned about reaching in the highly myopic eyes. So I think in highly myopic eyes, we normally start with a 23 gauge rather than 25 gauge. And sometimes even the 23, so now DOC is making, on maybe some other companies also, an extra long forceps. So I think that's helpful. The other thing I was just wondering was when you remove the PFCL, have you noticed that sometimes the flap can again move while you are kind of removing, although the PFCL is keeping it nicely stuffed there, but when you remove it, the flaps again start.
So that's a good point, sir. The thing is that we remove it from the disc and try to keep that bubble on the macula till the longest time that we can. But you're right, sometimes it can happen. But on the other hand, we have noticed that when we use PFCL, it causes some change in the flap. I mean, there is some adherence to the macular hole. I don't know why, but I've shared it with other surgeons who also share a similar thing, that when we use PFCL, it just changes the surface of the flaps, that it remains sticky for some reason.
For some time.
So I don't know why that happens.
That's interesting. I think I'll also try it next
time. And I was not the only one. I thought that I was seeing it, but I saw that other surgeons are also reporting that. So fortunately, I've not seen, too many dislodgements.
And of course, you mentioned about the autologous graft, which is very good. But I think if that also fails, or in some other situations now, amniotic membrane graft is again also a possibility.
Think your center is doing some pioneering work, in the north, and I've seen the videos. Yes, sir. We always learn so much from you, sir.
From each other. Thank you. Thank you.